Hi, this is Dr. Goldkamp again. I wanted to go back and review what we covered last week in vitamin D. Now, for some of you, you realize vitamin D has been covered by everybody that has a little bit of education. Well, vitamin D is very important, especially in the time of COVID. I'm not going to get into the COVID application. It's pretty self-evident, and just Google it, and you'll get more than enough information. But part of the reason I wanted to go a little deeper into vitamin D is because you have countries like Finland that are giving vitamin D to everybody. You have countries like Scotland now started giving vitamin D to everybody to help treat COVID. And yet you have England retracting the information saying vitamin D is not that important. In the United States, we're kind of like up in the air. So I wanted to cover that it is important. We've already covered some of the functionality of it last time. And I wanted to show how can people be deficient? How can they know they're deficient? And what else should they look for? So we talked about last time, there's two forms of vitamin D, right? The 25-OH, this is a lab test, and the 125-OH. And so why don't you take both labs? You could if you wanted to. And I did that for about 16 years until I realized it's really not necessary. So, however, and sometimes there is a possibility that you do have to look a little further. So we talked about you could live in northern latitudes. At the same time, we said, well, the Inuits are not vitamin D deficient. Why is that? It's because they, culturally speaking, have a lot of liver from fatty fish. That's their vitamin D. Other than liver from fatty fish, there really isn't any natural source of vitamin D from food. So when people say, oh, there's vitamin D in milk, it's put in milk. It doesn't come from milk. There's vitamin D in mushrooms. Oh, spare me. That's vitamin D2, ergocalciferol. And unless you plan to take 14 truckloads a year of mushrooms, that's really not a viable source. So let's just put that to bed. It just doesn't exist, and there really is only one source, the sun, and or you're taking some form of fish liver oil. And obviously there were generations of people that took cod liver oil, and it actually served them very well. Cod liver oil has a high amount of vitamin A as well as vitamin D, and certainly you get your omega-3s. And so for some people, it's perfect. However, I think there's a cautionary note for taking cod liver oil around vitamin A. Vitamin A too high can actually suppress your immune system. If you're deficient, vitamin A is wonderful. It's just what you need. But let's not go too far. Sometimes things are a little complicated. So we talked two forms. We said, okay, being outside and getting the sun is important. We talked about if you live above 37 degrees north latitude or south latitude in the southern hemisphere, that's a factor. But if you're never outside, it really doesn't matter what latitude you live on or don't live on. So for instance, I've had many patients that come from Florida and Texas, I'm thinking Arizona, New Mexico, and yet they're vitamin D deficient. You say, well, why could that be? That's well below 37 degrees. Well, it's because they really didn't go outside enough, or they put too much on in terms of lotion, suntan lotion, or preventative. And so you can go too far with that, and you can cause a self-induced deficiency. So what do we do? Okay, so then we came to the idea, well, you're going to supplement. You're going to supplement with D3. And we've talked about add the K2, and ideally add some magnesium as well. Okay, that would be a way. But what's this other way that people can be deficient or actually not be getting enough and not know about it? That has to do with looking at your genome, genetic aspect. It's a mutation. It's a common mutation, so they call it a polymorphism. So polymorphism is a mutation. It could be good or could be bad. Most of the times it slows things down a little bit. And so at this situation, there is, relative to vitamin D, there is a vitamin D receptor mutation. In fact, there's 3 of them. And that's what I wanted to show you today. There's 3 different mutations. And if you were to have these mutations, you would be somebody who would really probably have to take a higher dose of vitamin D. And you would also have to get checked more frequently. And also, your physician or who's ever following you, or you're going to have to look for a larger context of how you're doing. If you're always getting colds and flus and you're taking vitamin D, then you will probably have to take more if you know you have a vitamin D receptor problem. So let's talk about this. So when we looked last week, we looked at, here's a range of people that I simply pulled from the people who have come through our program, some of our clients and patients that have a big range. Look at, you have 7 as a low, then 10, and the high there was 75. So that's a big range. If you gave everybody vitamin D, let's say 5,000 IUs per day, some people would go, wow, that's amazing. You've changed my life. The person that was at 7 and the person was at 10. But the person who was at 75, that might be too much for them. They were already doing fine. And either they would have noticed nothing or perhaps they might have noticed excess. So it's not one size fits all. That's the problem. That's exactly the point I'm trying to get across. It is not one size fits all. I'm sorry, a little discretion is required here, but not much. So we're going to assume you have gone to the lab and you have got this particular lab down. Okay, so now you know your number and you go, oops. Well, actually, let's say that you're the person that's at 55. That's a pretty okay number. I would say work to get to 70, 75 and hang at that number. But you may have something else you haven't looked into. So let's look at that. This is 5 people who they've had their genome looked at, and I just took out the portion that had to do with VDR, vitamin D receptor. Pretty straightforward. I'm not very clever with that acronym. And so these are the 3 mutations, the polymorphisms, that slow down, that it's basically an altered receptor to vitamin D. So you could have normal levels of vitamin D, but it just isn't being metabolized very well. So let's look at people who have had this. So I put from the top, what we have here is not everybody has all 3 polymorphisms or all 3 SNPs. So the first thing is, do they have all 3 SNPs? And the second is, do they have it on both chromosomes or do they have it on just one and not the other? Well, the top here is what they call heterozygous, right? It's plus on one, minus on the other, plus on one. So they have 2 receptors, polymorphisms, on the same chromosome but not on the other. So they have a very minor problem. And by the way, these are from, the top 3 are from Northern European ancestry. So now we drop down to another Northern European ancestry, and this person does not have all 3 receptors, but has 2, which is homozygous. It's on both chromosomes. This person would definitely have to take higher amounts of vitamin D than the normal person. I would say this person would probably be looking at their normal of around 100, but also putting it in the context of other labs, like you saw on that last spreadsheet, would be a wise thing to do. What else is going on? If everything is fine, then I wouldn't pay too much attention to this. But if it's not fine, then I would definitely say this is something that can be improved. We have to run at higher levels of vitamin D for this particular individual. So now we go down to another person has all 3 mutations, is homozygous for one, is heterozygous for the other. So that is a compromised situation as well. All in all, which is worse? I would say this would probably be worse here than this, and these other 3 are pretty negligible. But what I'm saying, it is very common for people to have the vitamin D receptor, the VDR, 3 mutations, either heterozygous or homozygous, and that needs to be looked at. So it's no longer one size fits all. I hope you're buying into this now. It's not one size fits all. It's that let's go deeper with understanding who you are. So with the right person, let's say that person that had 7 for a lab value, and if they had 3 mutations, let's say they were this person in the middle here with both homozygous, that person would probably be profoundly affected by taking vitamin D, not only getting them out of that serum blood test level and inching that up, but the fact that they were really getting probably no vitamin D effect at all. They need to be running higher, as I said. And so gradually over the subsequent months, probably in 6 weeks, they'd come in and get another blood work and then another blood work. Obviously, you don't need to get your genome tested again. But that would be something that would directly affect this person's immune system. It would directly affect their bones if that's the issue. It would affect, it's On and on and on. Much to talk about in vitamin D, but it was about how do we know what's appropriate for you? This is how we know what's appropriate for you. Pretty straightforward. So when people say, oh, vitamin D, just take, 5,000 IUs a day. Well, clearly that's better than nothing. But if you're a person that's already in the high 70s or 80s and you're taking 5,000 IUs a day, that might be too much. And there are consequences of having too much vitamin D that has to do with your heart, has to do with your joints. And so a little is being appropriate, and being aware of what's appropriate is the goal to this particular video. So till next time, take care.